Hi, good evening, everyone. I almost said good morning. Good evening, everyone. Welcome. This is the DCM Foundation webinar, Ask a Heart Failure Specialist. We're very excited you all could join us tonight. As usual, all participant microphones are on mute upon joining, but we do ask that you drop any questions into the Q&A feature during tonight's webinar. We have a Q&A feature function at the end of the hour. We'll get started in just a moment here. We're letting some folks join. My name is Jayanne Rock. I'm with the DCM Foundation, for those of you who haven't seen me before. We do these webinars monthly, and we also have a monthly newsletter. If you have signed up for this webinar and you're not familiar with our newsletter, you will be getting the next newsletter, which comes out in March. So stay tuned for that. Again, we do request that you just drop your questions into the Q&A feature at the bottom of your screen, because we will be having a Q&A section after the speaker tonight. All right, why don't we get started again? Everyone's microphone is on mute upon joining. Give people a few seconds here to join. Why don't we go on to the next slide and get started? The DCM Foundation's mission is to provide hope and support to patients and families with dilated cardiomyopathy through research, advocacy, and education. Next. Again, we ask that you submit your questions. We do have the chat function is turned off, so if you do have any questions, please drop them into the Q&A. And let's continue. We have a lot of ground to cover tonight, so first of all, we would like to know who's attending tonight's webinar, and we'll put up a poll for you. Are you a patient, a family member or friend, a medical professional, or an industry professional? And I would presume we'll have a lot of patients and family members on tonight. Just give it another couple seconds. Okay, let's end the poll and share the results. Great, we have about 3/4 of the audience are patients and about 1/4 are family or friends, so that's fantastic. Okay, let's continue on. Tonight, I am so excited to introduce you to Dr. Kathy Crispell. Dr. Crispell is a cardiovascular disease and advanced heart failure transplant specialist. She did her cardiovascular training at Oregon Health Sciences University in Portland, Oregon, where she participated in research with Dr. Hershberger, studying DCM in families. She was later recruited by Northwest Kaiser Permanente, where she serves in roles as the Chief of Cardiology, Director of Cardiovascular Services, and Chief Medical Officer. Dr. Crispell retired from KPNW in 2015, but continued to work part-time at the Portland VA Medical Center and at OHSU as an adjunct associate professor. Additionally, she has been a volunteer physician in Myanmar and Ethiopia and provides telemedicine cardiovascular consultation to remote clinicians in Oregon and Washington. Dr. Crispell, thank you so much for joining us tonight. We're so excited to have you. Next slide, please. And with that, I will turn over the presentation to you.
Thank you, Jayanne. That was a very nice introduction, and it's so nice to be with everyone again tonight. I helped do a webinar last April, I believe, so it's nice to be back. Well, let me just tell you about the format for tonight's presentation. I'm going to do a very brief overview of DCM and some issues relevant to patients and their family members and friends. And then hopefully about half of the session will be question and answers. And so let me get started here. So DCM, just a brief overview. I think most of you may already know this, but DCM stands for dilated cardiomyopathy. Cardio means heart, myopathy means muscle disease, and dilated means that the heart chamber has dilated, has enlarged. And if you look to where my arrow is, this usually refers to the left ventricle of the heart, but it can also apply to the other chambers of the heart. And in the diagram here on the upper right, the left ventricle and the left atrium are enlarged, if you compare that to the normal heart to its left. And if you compare it to a hypertrophic cardiomyopathy heart at the bottom left, where you see the heart muscles quite thick and small. So we're talking about dilated cardiomyopathy. Okay. And I'm having a little technical problem here because I can't see the advanced arrows on my screen now to advance the slide. Okay, thank you. Okay, so this is an echocardiogram of a dilated cardiomyopathy heart here on the bottom left, comparing it to a normal. So the normal, we're looking at the heart kind of upside down and backwards. So the left ventricle is on the right side where my little arrow is, and the left atrium, right ventricle, and right atrium. If we kind of transect the heart longitudinally, that's the view we're looking at down here. And you can see that the left ventricular chamber is quite dilated and the heart muscle has thinned out. So that's very typical for dilated cardiomyopathy. Next slide, please. So one of the important things about dilated cardiomyopathy from a patient's point of view and from family members and friends is that no two patient paths are the same when dealing with this disease and condition. This isn't totally unique to dilated cardiomyopathy, but it's something important to keep in mind when dealing with people who have dilated cardiomyopathy. Next slide, please. Now, I really like this slide because, and I won't go through it in detail, but you can take a look at it later when the slides are posted online. But it kind of tells us why everyone is different. And this wavy line is really the patient path. And everyone has a different path. So everyone, though, has ups and downs with their disease, And the authors here have divided up the course of the disease into kind of stages. And there's the pre-diagnosis, the initial treatment, second stage, and then living with the condition, which is the third and kind of the longest stage here. And the little numbered circles correspond to this stage. And so, it explains why the paths are different for everybody. Everyone's life before they were diagnosed is different. They have different life circumstances, their activities are different, their emotions are different, their relationships are different. And, when their disease presents, the symptoms may be different as well. And if you follow the path here, their initial treatments may be different, who is taking care of them, who diagnosed it, what their first discussion was about the dilated cardiomyopathy. It may be very different from one person to another. How they feel about all of this may be very different. And this type of support that they're getting is different. And then if you go into the stage of just living with the condition, there can be many differences, how they're being monitored or maintained, over time, who's taking care of them, what kind of access do they have? Maybe they don't have ready access to specialists, and that puts a whole different light on how they are living with their condition. So everyone has a different pathway. Next slide, please. So here's a poll. We'll stop here for a second. Second poll is, how comfortable are you with reaching out to your cardiologist when you have health questions? Very comfortable, somewhat uncomfortable, or very uncomfortable. Give you a few seconds. Okay, I think we'll close the poll now. Let's see what the results are. That's great. I'm glad to see that people are very comfortable, but there are some people that are just somewhat comfortable and some people that are somewhat uncomfortable. So that's important to know, and a few that are very uncomfortable. Okay, we'll go on to next slide, please. So that actually is a good segue into getting the right care by the right physician. That's very important with your condition. Next slide, please. So dilated cardiomyopathy patients should have a cardiologist as part of their care team. And they should ideally have a cardiologist that specializes in heart failure. And why is that? Well, because not all cardiologists are, experts at taking care of people with chronic illness. And heart failure cardiologists are. They take care of people with chronic illness sometimes for years and decades. They will follow patients. And they also are, know the current information about DCM medicinal treatments and other DCM therapy options. They probably know the most about the genetics of dilated cardiomyopathy out of all the cardiologists. And they are often involved with DCM research. They often work part of a care team as well. Dilated cardiomyopathy or DCM can be sometimes very complicated to take care of. And there can be many specialists involved in taking care of them. And so having a team to take care of DCM patients is often very helpful. But not, all teams are the same. It really depends upon the practice your cardiologist may be in. And there could possibly be a heart failure specialist that doesn't work as part of a team. But most of the time, I would say they are part of a care team. And those care team members can be nurse practitioners and physician's assistants that have expertise in DCM, nurses who have expertise in DCM, other cardiologists who see a lot of DCM patients like electrophysiologists. Those are cardiologists that specialize in heart rhythm abnormalities, genetic counselors, social workers, financial specialists, and dietitians can also be members of the team. Next slide, please. So how do you find a DCM specialist? Well, as I mentioned, not all cardiologists are the same. So find out if there is a heart failure transplant specialist close to you. And if you live in a large metropolitan area, you're not going to have a problem. Many academic medical centers will have many of these specialists. If you, there are also probably many private cardiology practices, that is non-academic, I mean to say, that have at least one of these specialists, and some have several. So you won't have a problem if you live in very populated and in large metropolitan areas. But if you live in more rural, less populated areas, it may be harder to find these kinds of specialists. But I think it's important to be a good self-advocate. So start asking your doctors, especially if you have a cardiologist, ask them if they know of a heart failure specialist and where one might be. Some of these specialists travel to rural areas and have clinics. And for example, I live in a rather rural area in Eastern Washington. And the closest area to me that has heart failure specialists is about 60 miles away. But they do travel, and they have a clinic in my town of 2,000 people about once a month. So that kind of situation can occur. So it's important that you ask a lot of questions, that you be a good self-advocate, and you may have to do a little searching to get in contact with one. Another important thing to know is to understand your insurance and what your insurance will cover. That is, can you self-refer to a heart failure specialist or to a cardiologist? Or is a referral required by your primary provider or by a primary cardiologist? So those are some of the important things for you to be aware of. Next slide, please. These are some of the topics that are important to discuss with your cardiologist and heart team. They're not all the topics that you should be discussing, but these are some of the important ones. Why are you taking specific medications? You know, it's important. You don't need to know exactly how they work and what exactly they're doing, but it is important for you to know which medications are for your dilated cardiomyopathy, and you know which ones are really expected to help you live longer. That's what these basic medications are doing. They're helping you to live longer and to have less complications from your disease. And some of them may help improve your heart muscle function. So it's important to understand those things. It's important also to understand your signs and symptoms of a decompensation or when you're getting worse. Sometimes those signs and symptoms can be very subtle. So it's important to understand what to look for. And if you do identify that you are decompensating or not doing well, what do you do about it? Who do you notify? Are there certain things that you can do at home that may help improve your condition? So that's very important to know and to discuss. It's also important to understand what your treatment options are. I think of the treatment for dilated cardiomyopathy as a tiered sort of thing. So you start off with basic medicines, and then you can build upon that if needed. And those options include device therapies like ICDs or biventricular pacemakers, even left ventricular assist devices, and then if needed, later, perhaps transplant. So, you know, you don't need to understand all those options at the very beginning, but just it's important for people to know that those options are there. It gives people hope. It's also important for you to discuss what level of activity is safe for you and how to identify when you might be overdoing something. And lastly, it's really important to discuss your family history with your cardiologist or team, especially if you have had relatives that have been diagnosed with DCM or if it had sudden cardiac death. And you should ask about the role of genetic testing and counseling for you and your family members. Next slide, please. So this brings us to our next poll, and this is a multiple choice question. So where do you seek answers to your heart health questions? My cardiologist, my general practitioner, Google, Facebook groups, family, or friends. And you can mark as many as you want. Okay. I think we've had enough time here. Let's go ahead and see what our results are. All right, so that's great. That is great. So most of you feel very comfortable asking and seeking information from your cardiologist. That's really great to hear and to know. Thank you. Next slide, please. So let's go back to genetics for a minute and discuss why it's important to get genetically tested. DCM can run in families, and 20 to 30% of individuals with DCM will have another affected family member. And that's called FDC, or familial dilated cardiomyopathy. And most of the time, FDC appears it appears to be inherited as what we call an autosomal dominant trait. And that means that every child of an individual who carries the mutation for DCM, every child has a 50% chance of inheriting that mutation. So that's very important. However, not all individuals who carry a mutation will have or develop signs or symptoms of the disease. And that's known as reduced penetrance. So how that mutation expresses itself is reduced in those individuals. But even if someone has reduced penetrance, they still have a 50% chance of passing on that mutation to their children. So that's important to understand. Another important thing to understand is that DCM can be genetic, even if there's only a single person in the family that has DCM. People can be born with genetic mutations that are not inherited. And so it's important to understand that. So that's why it's important to get genetically tested. Next slide, please. And as I've mentioned, and just to emphasize why it's important to be genetically tested, we've already discussed a little bit about it's important to identify known mutations and get genetic counseling if you've been identified with a mutation. And if you have, then it's important for your children and other relatives to be tested. And then if it turns out that your relatives and children have the mutation, then it's important for them to get genetically or to get genetic counseling and to be monitored for signs of disease, perhaps be considered for early treatment that may alter their disease prognosis and course. And then they should understand that their children should be genetically tested for the same reasons. And lastly, by being genetically tested, that may present opportunities for participation in research studies that are evaluating treatments for DCM and prevention strategies for DCM, and to gain a better understanding of the genetics related to DCM. Next slide, please. So just in summary, this slide just shows on the bottom here that, you know, there are genetic mutations that we know about. And some of these genetic mutations can be influenced by environmental factors. It's not always black and white. Actually, most of the time it's not black and white. But these genetic mutations can be influenced by environmental factors. For example, there are certain drugs that are treating other kinds of diseases like cancers that can influence and unmask a genetic mutation. The state of pregnancy can be a condition that may unmask a genetic mutation. Alcohol, infections can, other factors can, and then they can lead to the expression of dilated cardiomyopathy. Next slide, please. So in summary of, in discussing genetics here, I just wanted to relay to you a story about Jen Rowe. Jen Rowe was one of the guest speakers during the April 2021 webinar, and she was a young woman who had peripartum cardiomyopathy who presented very ill shortly after the birth of her second child and ended up needing getting an artificial heart and later transplant. Unfortunately, has survived and has done quite well. But in preparing for the webinar, I asked Jen if she had been genetically tested, and she said no. And I was surprised because she's being taken care of by some very good and well-known heart failure specialists. And now let me just back up for a minute. So you might ask, well, why hadn't she been genetically tested if she's being followed by a heart failure specialist and you're recommending that we see a heart failure specialist? Well, people like in Jen's case who were really, really sick at the beginning, the people's main focus of attention is really on how to save her life. And so, you know, that's what they really have been focused on. And the you know, genetic testing kind of just got lost and dropped through the cracks, I think, because of that. But Jen is a great self-advocate. So when I asked her about that, she said, you know, I'm going to go ask my cardiologist about that. And she did. And so her cardiologist said, yeah, you're right. You should be genetically tested. And she got tested, and it ended up that she has a known mutation that is associated with peripartum cardiomyopathy. And she is so thankful that she was genetically tested, because she will have her children genetically tested, because she knows that each one of them have a 50% chance of inheriting that gene. So that's a personal story of the importance of genetic testing. Next slide, please. So the last poll is, what do you do if you feel uncomfortable with cardiologist answers? Nothing, just take what they say. Search for more information on the internet. Ask for a referral or second opinion. Seek out a heart failure expert in my area. Give you a few seconds to think about that and answer that. Okay, let's see what the answers are. So no one answered nothing, just take what they say. Good. Search for more information on the internet, but ask for a referral or second opinion was the most common answer. And then the second most common was seek out a heart failure expert in my area. Okay, that's good. Very good. All right. Next slide, please. All right. We're going to head on into questions and answers here in a few minutes. But first of all, I'd like to introduce Dr. Ray Hershberger, who has also given webinars in the past. Because Dr. Hershberger is a expert in the genetics of DCM, and we're very happy to have him here today to help answer any of your genetic questions. Dr. Hershberger is a professor of medicine and a heart failure transplant cardiologist and clinical and laboratory scientist who is the founder and principal investigator for the DCM research project. He and his group continue their research efforts to discover and understand the genetics and genomics of human dilated cardiomyopathy and translate new knowledge into the practice of cardiovascular medicine. Dr. Hershberger is at Ohio State University College of Medicine, and he directs the Division of Human Genetics in the Department of Internal Medicine. So thank you, Dr. Hershberger, for joining us and being our genetic expert tonight. All right, well, next slide. So now we'll open it up for questions and hopefully good answers, but questions from the audience. And you can ask anything, doesn't have to be on anything particularly presented in the talk tonight. And we'll try to answer your questions as best as we can.
Great. If you would like, I can tee up the questions. We have a couple that came in via email ahead of tonight's webinar, so I might start with a couple of those. This question, I was diagnosed with dilated cardiomyopathy in 2004. Is reduction in exercise time due to fatigue, windedness, part of aging with this diagnosis?
Yeah, that's a good question. I don't, if you have dilated cardiomyopathy, and that's a known, then I don't think you can assume that short windedness or shortness of breath is just related to age. You know, it could certainly be related to your dilated cardiomyopathy. And, you know, there are many factors that can play into that, but, you know, sometimes that can be depending upon the severity of your dilated cardiomyopathy. That could be a chronic sort of symptom, but hopefully not a, you know, a really limiting symptom. If it's a really limiting symptom, that's pretty important and significant, and I don't think you could chalk it up just to age. So yeah, something that you should definitely discuss with your doctor.
Okay, excellent. This also came in beforehand. How do you recommend patients manage their anxiety after being diagnosed with DCM? And are there any safe meds for this? And I'm sure the med question, they'd have to refer to their cardiologist, but how do people deal with the anxiety of being diagnosed?
Yeah, that's a good question, and there's not a good single answer to that. You know, people deal with it in different ways, and depending upon where you're getting your care, it depends upon what kind of resources are available to you to better, you know, to be able to help you with this. but some people, you know, deal with their anxiety through medication, being prescribed certain medications that can help with that. Some practices actually have counselors that that deal with you know, certain kinds of diseases that can cause a lot of anxiety. And so, you know, if that is available to you, that can be very helpful to some people. And I have worked in practices that have had that option, and that seems to be very helpful. And in addition to that, the that kind of practitioner can also involve the family to let them know, you know, and help them help the patient. And so so that's another option. And it's important to discuss this with your physician, your cardiologist as well. Sometimes anxiety can be a symptom of your dilated cardiomyopathy or of heart failure.
Oh, interesting.
So so some people, and I've seen this, I'm sure Dr. Hershberger has seen this, where, you know, people are thought to be quite anxious or have a you know, have chronic anxiety, where they have actually had undiagnosed heart failure from dilated cardiomyopathy, and it's been treated as if they have an anxiety disorder. So it's important for people to really talk to their cardiologist and see their cardiologist, make sure that they do not have decompensated heart failure as a result of their dilated cardiomyopathy.
Okay, excellent. Thank you. This question, and I'm going to have a follow-up, is for Dr. Hershberger. What percentage of DCM cases are idiopathic?
Yeah, it's a great question. So dilated cardiomyopathy, again, as Kathy explained, the left ventricle is large, and that is a definition of size. And so you can get an enlarged left ventricle from a variety of different causes. Probably the most common cause is a really bad heart attack that takes out a lot of heart muscle. So the rest of the heart muscle gets weak and dilates up. And that would be a dilated cardiomyopathy that is from coronary heart disease or heart attack. That's probably the most common. The second most common we call idiopathic, and that's after we have excluded other, what we say, detectable clinical causes. Heart attack would be the most common. And so if somebody comes in with a dilated cardiomyopathy, presenting heart failure, the most thing commonly we will exclude coronary heart disease and then other less common causes. The other causes that would be on the list, if someone had cancer chemotherapy, that can also trigger off a dilated cardiomyopathy. There's actually a fair amount of data now to show that a genetic background in combination with the chemotherapy will cause a DCM, but coronary heart disease. And then, so the answer to the question though is, in terms of what frequency, depends a little bit on what series you look at, but in general, it's about 50-50. About half the time it's coronary heart disease, about half the time idiopathic, and then sort of in the 5 to 10% range, these other causes. I would also mention valvular causes. Usually valvular cardiomyopathy, we think of as a specific type, and we don't normally throw that into the dilated cardiomyopathy classification. So.
Okay, all right, excellent. This is a generally related question about genetics. Having been diagnosed with DCM and ultimately transplanted, at what age should my children be genetically tested? Now, I'm assuming this person also had already been genetically tested and had some sort of mutation. When should children then be tested?
Yeah, so if you have a known genetic diagnosis for your cardiomyopathy, testing of children can really be done at any time. It depends a little bit on the age of onset of the patient. again, in genetic studies, we call this the person the proband, but sorry if I use this proband terminology, that's how I think. But so if the proband actually was diagnosed in their teens or 20s, so there's early onset. So the children really could be at risk of dilated cardiomyopathy. Dilated cardiomyopathy is not very common in children, but it does happen. And I've actually seen it in my own experience as a transplant cardiologist, transplanting a young person actually at the Oregon Health and Science University. Kathy probably remembers this case. And the young mother, the father was transplanted and in his early 20s, and the young mother just had a baby a few weeks after his transplant. Holding the baby, said, Dr. Hershberger said to get this patient, he doesn't sound right. He isn't right. He actually had dilated cardiomyopathy. It's very unusual. The only case in my career, so it can happen. Now, we have just published a major paper in a medical journal just a couple of weeks ago that shows really for the first time that the younger you are at diagnosis, the greater the risk of identifying a genetic cause and the greater the risk in family members. So again, answer the question, if you have early onset DCM and you have children at risk, then really clinically evaluating them, certainly in their teen years, is indicated. On the other hand, if the onset is in the 40s, 50s, 60s, and no one in the family has ever had disease, in their 20s or 30s, you probably don't have to worry about testing children or adolescents, but certainly young adults, when they hit their 20s or 30s, definitely would want to have them clinically tested. Again, back to the genetics. The power of genetics, if you have a known mutation in the family, if you test and a child does not have it, in general, they're off the hook. And that's the value of genetics in the family. On the other hand, if they do have the variant, they have the mutation, they're at risk. Then depending on what that mutation is, depending on what the gene is, what the age of onset of the family, how aggressive they need to be screened and how frequently, that takes a bit of judgment. I'll stop talking before I take up all the time here. So.
Okay, no, that's fantastic. No, thank you so much. This question is for Dr. Crispell. In general, let's take it from the beginning. What are the typical initial symptoms of DCM?
Yeah, that's a good question. It can vary. Often it's fatigue is an early symptom, but it's pretty profound fatigue. I mean, I'm talking about fatigue that really limits what people's normal activities are. They're just too fatigued to do what they normally are used to doing. It's that kind of fatigue. Mm-hmm. But it can be subtle, and people are excellent at making up all sorts of excuses for those kind of symptoms, like, oh, I'm getting older, or I'm under a lot of stress or whatever. So sometimes it can be very subtle. Shortness of breath is another common symptom, and that's usually from congestion, fluid retention that has slowly been going on, and now the level of fluid retention is severe enough to be causing shortness of breath. There's not enough room in your lungs for good air exchange because there's fluid there now. And so and it's amazing how well people will also compensate for shortness of breath. They may just think, oh, I'm slowing down, or again, I'm getting older. But if you could walk up a flight of stairs in your home without any problem 6 months ago, and now you're huffing and puffing when you're getting up there, that's a limiting symptom. It's limiting what you used to be able to do. And certainly any shortness of breath that it's occurring at rest is a very significant clinical symptom. And so people can, and I have seen patients, I know Dr. Hershberger has too, that, have had resting shortness of breath for many months and have just put up with it because they didn't understand the significance of it. But if you cannot lay down flat because you can't get enough air in, and you have to prop yourself up in order to get enough air in. That's shortness of breath at rest. And again, it can be a very significant symptom related to heart failure, or which can be related to dilated cardiomyopathy. If you can, if you can lay down at night and, sleep initially, but you wake up in the middle of the night feeling like you're smothering or you can't get enough air, and you have to like stand up and for a while, or walk around for a while, or feel like you have to open the window and get some fresh air, that's another very important symptom of, again, shortness of breath at rest that can be a significant sign of heart failure related to dilated cardiomyopathy. Fluid retention is another sign. So, the shortness of breath is most often caused from fluid retention in the lungs, but you can't see that. And but sometimes people notice that they may have other signs of fluid retention, like increasing swelling in their lower extremities, or an increasing belly. Fluid can accumulate in the abdomen, and people may have to loosen up their waistband or loosen up their belt because their abdomen is increasing. It's being filled up with fluid. And fluid weighs a lot. If you've ever picked up a gallon bucket of water, you know that fluid weighs a lot. So, if you are retaining fluid, you could be seeing an increase in your weight as well. And so that could be another sign. That can be tricky though, because sometimes people with significant heart failure that hasn't been diagnosed yet, they can also have loss of muscle mass, and you may lose weight as a result of that. So weight could stay the same or be even a little less, or it could go up. But weight changes are important to notice. So I would say those are some of the more common early symptoms of heart failure.
So in general, it sounds as though, and I know we've talked about this before, but no two patients' journey with DCM is the same, and everybody's situation is slightly different. And one of the questions that's come up a few times and came up again here tonight, we have a lot of questions coming in, so that's fantastic. Can you explain how the stages of heart failure work and how this is a progressive disease? And we get a lot of questions about the stages of heart disease and heart failure, and that could be a whole webinar in itself, I know.
It should be. It should be. We have, let me interrupt you, Jay, and we have 27 open questions. I think what Kathy and I should do is just start going down the list and just answering a whole bunch of them, because I mean,
fantastic.
It's terrible.
That sounds great, because
Yeah,
there are a lot of questions coming in.
Rather than me going on for 5 minutes, I'm going to start with Jane Clark at 613. A clinical trial tested positive for the gene, but her tests were normal. What are her chances of developing DCM? They're significant, but I need to know a little bit more about the gene and the variant. And Jane, if you were in the DCM precision medicine study, the one we just finished and published, be in touch. We'll give you some more information. Can you see the questions, Kathy?
Yeah, I can see them.
Let's see. Is genetic testing important if you're older, childless, and siblings have been tested? It depends. There's a couple of related questions. Testing can, depending on the gene, lamin would be one, a nasty gene for arrhythmias. So if you test positive for a gene that has a nasty arrhythmic phenotype that will increase your risk of sudden death, there could be reason for you to be tested rather than just to test to see if your children are at risk. Yeah, here's a question followed by Michelle Hamilton, Christina McGinnis, Cedar Sinai. I know Michelle Hamilton very well. Diagnosed at 71 years with DCM, wondered if it was and wondered if it was a mutation. Why did it take so long? Again, age of onset is quite variable. We don't have all the explanations. We think that there is a genetic background for that. Some of it may be environmental. Stay tuned. We're going to be analyzing our genetics in the DCM Precision Medicine soon. Is bariatric sleeve surgery okay? Yes, bariatric surgery is okay. How do you prevent kidney problems on diuretics? We ought to have a seminar on that one. I'm going to skip that question, but in general, if you're well managed, it isn't the diuretics, it's the heart failure that's going to do you in and do your kidneys in. That would be the global answer. I'm going to skip some of these, but I was diagnosed September 2021. My AF is 26%. We do not have any history of heart problems in my family. I did have genetic testing. It was positive. How hard? I do have to have a defibrillator in soon. How hard is the surgery? I'm very scared. Yeah. I'm a heart failure transplant cardiologist. Defibrillators are kind of like, it comes with the territory. And of all the things in heart failure transplant, you needed, if your doctors say you need a defibrillator, get it done. It's really important. You don't have to die from an arrhythmia anymore. I've been through, Kathy and I, back in the old days before we had defibrillators, we lost so many patients. Any initial suggestions for newly diagnosed 23-year-old? Yes. Kathy's talk up front. You need to see a good heart failure and or transplant cardiologist. You ought to have genetic testing. Generally, when I see a new idiopathic dilated cardiomyopathy in a person in their teens or 20s, it's highly likely genetic. We may not be able to find the genetic cause, but it's almost always genetic.
Ray, can I interrupt you
Yes,
just for
please.
a second?
The questions keep piling in. We can't catch up.
I know. Would you both be willing to stay on till quarter after the hour to try to get through some more answers? And if people need to drop off, that's fine. We'll just try to get through as many as we can. And so, okay, go right ahead. Thank you.
Yeah, that
Kathy,
sounds
you go ahead, Kathy. You take some. I'll catch my breath.
Well, I just saw that Diane Brown has a good question about the Titan mutation and HMY6 variant. Do you want to answer that?
I was going to take that one next.
Okay.
So this is Diane Brown says, I have a Titan mutation. Titan, the most common genetic cause of dilated cardiomyopathy, in an MYH6 variant. MYH7 is a common DCM gene. MYH6 is less common, and its role in DCM is less understood, although it undoubtedly has a role. It's harder to nail down. I gave the mutation all four of my children. 3 thus have developed DCM, and the 4th is borderline and being watched. Is a combination of mutations increase the probability of passing it on to children? So again, autosomal dominant inheritance, each child 50-50 chance. So it's just really bad luck that all 4 children actually inherited the Titan, assuming it's the Titan variant. And we see this. And then if they each have it, and yes, the question of if you have multiple mutations, and again, we have data coming out on that, it's not published yet. There's no question that it adds up. And it makes it worse. And then what causes arrhythmia if it isn't scar? Again, that's a whole nother topic but in general, these variants, depending upon their mechanism of action, will disturb your intracellular stuff, your processes, calcium transients, and trigger arrhythmias, independent sometimes of the chronic scarring that goes on with long-standing dilated cardiomyopathy. In fact, Kathy, why don't you pick out the questions and you help choose, and then you answer them, or turf to me. You're really the MC here. So
I think the next question is actually a very important question too. Is what is the benefit of genetic testing if you're not going to have children?
Yeah, so that comes back to it's a very important point that as we learn more about the different not only types of mutations but the trouble they cause, the most compelling reason is arrhythmia risk. And I can name off, I won't name them off, but half a dozen genes which have much higher arrhythmic risk, which are or more difficult to predict. And so in the guidelines that we've written and published, we recommend an implantable defibrillator before the ejection fraction is less than 35%. That's a standard level at which you get an ICD if your ejection fraction hasn't improved above 35%. But if you're sitting on a laminin mutation or perhaps a DSP mutation or an SCN5, a variety of different mutations that we actually have knowledge about, we would not be comfortable watching you with an EF of 37 or 38%, thinking because of that arrhythmic risk. That's the most important reason. The other thing is it does give us some sense of prognosis, and we don't have medication specifics, but the other big thing that's going to happen, I think this decade, I certainly hope it's going to happen in my lifetime, is gene-specific therapy. Right now, we don't have, fixing the disease gene. You've heard about it in animals and in cells and things like that. It's happening in humans, not in dilated cardiomyopathy. It's happening in some heritable disease where actually genes get fixed. This is Cas CRISPR stuff. It hasn't happened in cardiomyopathy yet, but it can and it will. So that's the other reason to actually know what the mutation you carry, that you carry, especially if you have passed it on to your children, because I'm a transplant cardiologist. It's time we stop doing transplants in teenagers and 20-somethings if we can avoid it, if we can fix the gene. And again, that's part of what this whole thing is about, fixing these genes. So that's the reason. That's the ultimate reason to know. A little premature yet, but that's where we're going.
Yeah, I'll answer this this next question. The question is, with a very low EF, what's the risks of having a child? There's significant risk in having a child, and it presents a real problem because you may have to be withdrawn from many of your medications during pregnancy. And if your EF is already very low and you're on medications that are helping you live longer and hopefully can keep you in a stabilize your disease, if those medications have to be withdrawn during pregnancy because they can cause harm to the fetus, that's why they would be withdrawn, then your EF may fall. And you could have a very complicated pregnancy where you could decompensate. You could lose your child. You could lose the pregnancy. If you manage to get through pregnancy, you may be sick and unable to take care of your child. And then it's possible, you could improve once you're back on your medications, but once you had a severe decompensation with a very low EF, you may never really recover back to where you once were. That's another risk. And so there are very significant risks if you have a low EF and you become pregnant. Many cardiologists, heart failure transplant cardiologists would recommend that you do not get pregnant. And so I think that would be the common recommendation if you have a low EF.
Yeah,
you would
pretty scary.
agree?
Yeah.
Yes.
Yeah,
Mhm.
it's scary. I'm going to skip down to the very bottom question, Andrea, Gavin. Is it possible to genetically test an embryo to prevent passing on a gene? Yes, it's called pre-implantation genetic diagnosis. So if you know the gene and you do want to have children, it can be done. Of course, it has some expense to it and et cetera, but it can be done. It's very important.
Yeah, there's another question here about pregnancy from Yvonne. My genetic test was negative, diagnosed with DCM heart failure after pregnancy in 1999. Does that mean that my DCM was brought on because of this, or I had never had heart problems before?
Yeah. It's a great question. So the sensitivity of genetic testing for dilated cardiomyopathy is about 35%. Now, let me explain that again. when we know it's genetic because we have a family with multiple people who have inherited and passed on to intergenerationally, so we know it's genetic. The chance of finding the genetic cause is still 35, at most 40%. So just because you test negative for genetics doesn't mean it's not genetic. It just shows that we have more research to do to figure out the causes. Peripartum cardiomyopathy is one of those things that is not yet explained. Our data have always indicated that it has a genetic background, but not everybody agrees with that. And I would say that that is an unresolved question. And in fact, we have one of the people at Cedars, where Michelle Hamilton practices, Evan Kransdorf, is writing a paper right now on peripartum cardiomyopathy from the DCM Precision Medicine study. But it's complicated. But I would not exclude a genetic diagnosis for anyone because the testing is negative. We only know if it's positive that it's certainly genetic. And then of course, based on the family history, if it's been inherited, multiple family members affected, we know it's familial, and therefore we infer genetic.
So I'm going to answer this question. It says, I'm 43 with a history of chemo when I was 31 for triple negative breast cancer, 12 years cancer-free, and just diagnosed with DCM. Well, so that's an interesting situation and not uncommon. This is actually fairly common. So your DCM could be related to the chemotherapy depending upon what chemotherapeutic drugs you received. And it could be also that you have a mutation that could have, that can lead to DCM. And then, your exposure to these drugs were an environmental factor that has eventually led to DCM. So we don't know the answer to your question right now. It would probably still be advisable for you to get genetically tested so that and that your children would know if you have, a genetic mutation that they may have inherited. So I think it's very important for you to get genetically tested to answer that question.
I'm going to take this. How do you know if your cardiomyopathy is getting worse or as you age? It's serial monitoring, very important. You may not need an echo even every year, but you need to be followed with an echo periodically, generally every year, a couple of years if it's certainly low. And then you need to be followed for symptoms. And so we follow you clinically by symptoms, but we also measure things directly. And a cardiologist, we measure things directly with an echo on your heart size and your heart function. So that's how we do it. We can also do exercise testing and a bunch of other things to quantitate the degree of illness that you have. Very important that your cardiologist is following you.
I'm going to take a stab at this one, and I think Ray, maybe you can chime in as well. This is an important question. Can DCM be reversed?
Yes.
And so, that's a really interesting question and a good question. DCM, or the dilated part in the contraction part of DCM, the abnormal ejection fraction, the heart doesn't contract normally, and how much it has dilated up. Those two characteristics can be improved with medications in some people. The thing is, we treat everyone the same with the same medications because we don't know exactly who is going to get that kind of benefit. And, everyone gets benefit out of, some improvement, but some people have a fairly dramatic improvement. And I've seen people that have been diagnosed with pretty low EFs and on the right kinds of medications. Their hearts actually, their chambers get smaller and their ejection fractions improve, and sometimes they improve back to normal. But they may not stay that way if they go off of their medications. And so it's very important, if you've had improvement on medications, that you stay on those medications. And some people, some non-heart failure physicians are really happy to see that you've had an improvement in your heart muscle size and the heart muscle function, and they want to start taking you off of medications, or the patient themselves will say, hey doc, I'm tired of taking these medications. My heart is now so much more improved. I don't think I need these medications. I think the takeaway here is you must stay on your medications to maintain that kind of improvement. Yes, it may not necessarily be reversed, but you can get, some people can get dramatic improvements with the right therapies. What would you add to that, Ray?
No, I think you said it. Yeah, I don't have anything to add. I would, here's a question. What if a low EF does not improve?
Mm-hmm.
So it turns out that an ejection fraction does not automatically cause the degree of the badness or the degree of dysfunction of the ventricle does not necessarily go along with a decrease in what you can do in exercise capacity. They're not related. So sometimes people can have a low EF and be quite functional for years. But in general, if your EF is not improving, it's not a good sign. And so you have to fuss more, and we get more concerned, and we follow you more closely if that EF isn't improving with medical therapy.
I'd like
Here's
to
one
just
from Wendy Flowers. Sorry, go ahead.
Go ahead. Go to Wendy.
Hey, Wendy, are you seeing more younger people with DCM as a result of wider and early testing identification? I don't think so. I mean, when young people, well, I mean, in family-based testing, as people understand that dilated cardiomyopathy, again, the guidelines say that anyone diagnosed with new onset dilated cardiomyopathy, testing, clinical testing, an echo, an ECG is indicated in their first degree relatives, parents, siblings, and children. So we are identifying more family-based cases because of family-based testing. On the other hand, young people, if they're sick, pretty unusual. And if they have bad heart failure and they present, we've been seeing those for years, decades, and that hasn't really changed a lot. So.
Yeah, I'd like to just go back to this one question we kind of started off this little session with. I'm not going to answer it, but I'm going to, can you explain how stages work and how this disease is progressive? I don't want to blow off this person. And so, I would say, go to our website and look at the stages. And the stages are clearly explained, right? I hope they're clearly explained on our website. But stages refer to structural changes and symptoms that may be occurring as a result of those structural changes in the heart. And so the stages are A through D, and so you can go there and it explains. And then how this disease is progressive. Well, again, the disease can be progressive or manifest itself in different ways in different people. So in some people, it's not really obvious that it is progressive. It can kind of stay the same. In some people, it can be very rapidly progressive. That is, there's symptoms that just continue to worsen despite being on the best therapies possible. There are some people that get marked improvement after being diagnosed. They may be pretty sick when they're diagnosed, and they're quite stable for a long period of time, and then they get really sick again. So it's not predictable how the disease will progress in people. So I think that's kind of the bottom line.
I'm going to skip back up here. Have there been any studies on DCM as a result of COVID? The short answer is I'm not aware of DCM as a result of COVID. It's really a different mechanism, and in general, any illness, pneumonia, infection, COVID can make, if you have DCM, can make it worse, but I don't think that COVID causes DCM.
And I'm going to talk about, there was a question here, I just lost it for some reason, about, oh yeah, can you discuss further mechanical interventions if you start declining? So it depends upon all of these interventions have associated with them specific indications for them. So like an ICD really doesn't have anything to do with your how you're doing clinically, really. It has to do with what your ejection fraction is. And if you have an ejection fraction less than 35%, then you meet the criterion of having an ICD. And an ICD is just a preventive therapy to help prevent what we call sudden cardiac death, prevent death from these lethal heart rhythm abnormalities that can suddenly occur out of the blue. So that's an ICD. A biventricular pacemaker is different. There are certain kinds of criterion besides ejection fraction that one must meet in order to really qualify for having a biventricular pacemaker. And those are electrocardiographic findings, and also clinically how well you're doing. So, and then of course, there's more invasive types of mechanical interventions, such as left ventricular assist devices, which are really reserved to people that are very, very ill and really refractory to all the other therapies that we have. And then those people are being considered for left ventricular assist devices. And some of those people are then bridged to transplant as their kind of final therapy for dilated cardiomyopathy. So I hope that answers your question.
I'm gonna, this is one from Sarah Foy here about beta blocker and insomnia. It's unusual, but when you treat thousands of patients with beta blockers and ACE inhibitors, you find all kinds of what we call idiosyncratic effects, unusual, unexpected. So I believe it. And she swapped dosing from night to morning, and it helped. And so I believe it. I'm not sure I've actually heard of that per se. Beta blockers, that's a whole nother topic in itself. Interesting drugs, but it's certainly plausible. And then another anonymous comment, do you have any comments on the first pig heart transplant as a bridge? Well, it's not a bridge, it is the permanent transplant. And these pigs have been engineered. I think it's very exciting. We'll have to see what the ultimate outcome or implementation of that is. It could represent a sea change in how heart transplant is done. We'll have to see. I think it's a phenomenal achievement of biology to get those pigs genetically engineered so that we take out that hyperacute rejection between animals and humans. So very exciting.
So there's a question here, is metoprolol in a CRT-D enough to improve my DCM? That's an interesting question. So I can't really answer that question, and I'll tell you why, because there may be other drugs that you're taking for your dilated cardiomyopathy that you're not mentioning here, and I hope that is the case, because usually metoprolol alone is not the advised medicinal therapy for dilated cardiomyopathy. And so, I can't really answer, your question really, really well. So if you can provide more information later, then I might be able to answer it.
I want to, Susan Liebman has a couple of questions here. One is a very thoughtful question about, it really has to do with what's called gene first testing. The question basically is, further on down, Susan says, my family has an FLNC with a 36-year-old sudden death. It's horrible. I mean, it's horrible. I'm so sorry. FLNC, relatively more recently described gene, nasty arrhythmias. Again, that's another reason to get genetic testing. If you got an FLNC truncating variant, you need to know it because it causes sudden cardiac death. Susan's question then above is, what about testing people more generically, just people off the street to see if they have FLNC or other kinds of nasty mutations to try to prevent sudden cardiac death? It turns out, Susan, it's called a gene first strategy. And right now, it turns out it doesn't work because, and it's a complicated answer. It probably deserves a whole nother a seminar, but probably has to do with the genetic background in the setting of the rare variant, the common variant background, perhaps environmental, but probably the common variant background in addition to the rare variant that is really setting up the nastiness we see in some families. The short answer is, in large population-based studies, UK Biobank, a couple 100,000 patients off this, or not patients, people off the street who have had full genome sequencing, when they analyzed cardiomyopathy genes, some of them have absolutely no evidence of disease. So it would be, at least at this point, we don't know what to do with that data. So very interesting question, though, very important.
Yeah. So there's a question here about transitioning to Entresto for a young adult with who has had
Yeah.
DCM since infancy and been on, it looks like, appropriate medications. It's not an unreasonable thing to transition that person to Entresto. I think if he's doing, it really kind of depends upon what his clinical situation is and if he's been stable, but it's not an unreasonable thing. And there is experience with DCM and transitioning to Entresto. So, Ray, what are your thoughts on that?
Well, I mean, there has been progressively better drugs over the last 3 decades. And Entresto has shown superior effects to what we had considered conventional medical therapy. So yeah, I mean, it's a completely reasonable approach generically, and lots of patients who have been on ACE inhibitors and beta blockers and whatnot have been switched to Entresto, and that's great. They need to do it. So.
Yep. Okay.
How progressive is DCM in people with a Lamin mutation? The president of the DCM Foundation, Greg Ruff, has a Lamin. His stories on the website, so this is all public information. Has a Lamin mutation. Lamin cardiomyopathy is characterized by sort of a more fibrotic and nasty arrhythmic phenotype, and in general, the general sense is that a Lamin cardiomyopathy is progressive and less commonly will respond to medical therapy the way Kathy was describing. Some people, it's like magic. You put them on medical therapy and their EF gets a lot better and their heart shrinks down and they're back to life. Lamin, not usually not the case. So that would be my comment.
Okay, so Michael has given me some more information about his question about metoprolol and the CRTD. Yeah, so he's only taking metoprolol and Lipitor. And yeah, so you should be on an ACE inhibitor or an ARB or on Entresto, and as part of your drug regimen. And there may be some other drugs that you should also be on as well, Michael, but certainly at minimum, you need to be on an ACE, ARB, or Entresto as part of your medicinal regimen here.
We're at 7:13, so Jan said 7:15, so we'll obey you, Jan. So
I can stay on. We can.
No. I mean, these poor people. Anyway.
Well, we've had some really, really great questions tonight.
Great questions.
And
Really.
so I'm glad that we were able to get, and thank you, Ray, for because I wasn't even paying attention to the question and answer box. So I'm glad you were looking at that and kind of jumped in there so that we could answer as many as we could during our time here. So it looks like this was pretty popular, and we might want to consider having another long question and answer session in a future webinar.
Absolutely. I think what we'll do also for any of the questions that we didn't get to tonight, there were not too many, but first of all, thank you both. That was incredible. And thank you to all of the attendees tonight, the participation and asking questions. This is obviously super important to people. What we'll do is provide answers to those questions that we weren't able to answer live during the event. If people have additional questions, please, you can email me directly at jrock, JROCK, @dcmfoundation.org, and I'll do my best to get those questions answered for you. Thank you to Dr. Kathy Crispell. Thank you to Dr. Ray Hershberger for your time and assistance tonight and participation on the DCM Foundation board. We also want to take a moment to thank our generous sponsors, without whose support we could not do everything we do to bring you folks all this wonderful information. And again, please check out, there's all kinds of information, resources about the stages of heart failure. There's information about different patient stories, information about genetic testing and clinical trials. Go to dcmfoundation.org. And we also encourage you to follow us on social media. We have updates every week, Facebook and Instagram for sure. We have multiple posts a week and bringing you updates there as well. Next slide. And we ask that you hold the date for our next webinar. We'll be providing, of course, additional information via email. It will be held Wednesday, March 23rd at 6 p.m. when we will unveil the DCM Foundation strategic plan and explain what this means for you. And certainly we will welcome patient and family questions. And so as usual, we love to hear from all of the patients and families. So again, thank you all for participating and joining us. Thank you to Heather behind the scenes, helping us with technology again tonight. And we look forward to seeing you next month. So take care and be well. Thanks, everyone.
Yeah.
Have a good night.
Okay.
Thank you.
Thank you. Bye-bye.